provider free pharmacy program, and like everybody else, they're trying to do everything that they can to respond to the need. To bring it back to your question, I think it's really two separate questions because there's really two populations we're talking about here. There's the folks who, like most of us in this room, who have insurance, and those types of services are reimbursable, and that's the first battle you have to fight, is get it paid for, and the second is you got to get people to adopt it. I think there's a whole other population that is out there that's eating, Vienna sausages that are not going to have access to that and are not going to be covered, and they're going to fall through the cracks. So I think it's a really more complicated question.
That's why I think it really has to change rapidly. And I think, like you were saying, Alan, if the thing that scares me the most is that, and I'm a capitalist as well, but I think we can make money in medicine doing the right thing, not just doing things. And I think
real capitalists stand up.
Right.
I'm socialist.
So if you make money doing the right thing, my fear is that we're going to open the floodgates to a lot of people coming to a system that's broken. And that broken system is going to cost a lot of money. And I think that's going to force a lot of skate fires to happen quickly. And I think what we need to do is sit back and say, okay, how can we do the right thing, like the Safeway CEO, and make money in a system where we really do the right thing to help people live longer and happier and healthier lives. And that's something we've never done as a unit in medicine to do. But I think physicians are most in that position with good administrative partners to create that environment.
I would just comment real quickly that I think our other partner in that process, so just like Safeway, are the employers. So people like Paul Grundy that go out and speak on behalf of primary care. I mean, we may not be all aligned on the medical side, but I think primary care has a lot in common with employers in that we want to provide prevention and keep people healthy. And those may be the partners that can help us to tip the balance and work with us to create that change from volume to value.
Yeah, I said in a meeting at the Institute of Medicine, it was on value-based purchasing, and I was there with my Brookings hat on, but there were 5 or 6 CEOs of major Fortune 500 companies sitting in the room, and they basically declared that healthcare was their number one or two determinant of stock price. Their healthcare costs rising. They were going to fix it, and they all stood up one by one and told little snippets of how they were going to fix it. The nicest version was the Safeway version. The less nice was that they would rip jobs out of communities and move them where the care was better. And that was thousands of jobs, and gave examples how they had done that. And so I think that's why I say 13 and 14 is a huge issue. So I'll chime in with my socialist friend over here, but because the other part of the question is the public payers. I mean, the public payers, Medicare and Medicaid, is a pretty big chunk of the healthcare dollar. But I'll talk to my clinician. This is not an academic exercise or a policy exercise. If you look in your communities and your patients, and if you wanted to name the 5 worst patient scenarios of disjointed care and problems that you had seen around patients, who would they be? Not likely your employed patient. It would more likely be your frail elderly or your disabled or your disenfranchised, because they have the worst problems. We don't coordinate the care for them, and they consume the most money in the shortest period of time because we don't have systems to integrate the care. And also they represent the biggest cost shift to hospitals and everything else. And which is why we started with Medicaid on this. I mean, we talked about doing something else when all the primary care folks started talking about what do we do with healthcare 12 years ago. And we said, well, no one's going to get upset if we start working on Medicaid, it's kind of invisible to the system. Maybe we can figure out what to do. Starting to get people's attention a little bit because private industry is coming and saying, well, you guys got some stuff that really works. Maybe my employees would benefit from a little bit of a medical home and a little bit of some care coordination before even those. You guys were doing that before it was called medical home and care coordination, by the way. I think there is some opportunities here for us to make an incredible difference. Decrease the cost shift, the healthcare costs should come down for the private sector because of the cross-subsidization. At least that's my economic theory.
Thank you all. This is a wonderful movie, and thank you for your time tonight. As I was watching the movie, I was hopeful. There were messages of success, but it struck me that they were successful in that it was a system that put attention to a problem, and then in that they became successful in bending the cost curve, improving patient care. As a primary care physician, it's becoming increasingly more complicated to deal with different insurance plans, patients coming on and off of private plans, Medicaid changing their formularies on a regular basis, pre-authorization forms that are increasing. So it almost feels like shifting sand that you're working in at times. What I want to hear from the panel is, what are your thoughts about simplifying the system, creating one system, and not having to deal on so many different systems?
Sounds like utopia to me. No, it's not to be flip. I mean, I'd be interested in other folks. So how do we get to, what you're talking about is one single system multi-payer, not single payer. Well, single payer is a way forward to that, but not going to happen in our lifetime likely. So unless the whole system crashes. So how do we get to a single system? And is there alternatives outside of, you know, there's a lot of Cleveland Clinic group hugs in this thing, but that's not the only, you know, innovation that's going around the country, actually. So how do we get to that? I don't know if the panel has anything.
You know, that's one of the challenges that we have in our practice of about 50 docs is getting docs to see that, you know, when you ask every doc, do they do it right? Every doc says, I do it right. They all do it different. And it's not that it's different and wrong, it's just different. And sometimes it's not evidence-based, and sometimes it's not cost-effective. So I think what we've done as physicians is we haven't positioned ourselves to be more, as Alan says, have multi-payers, but let's create the system that's best for the patient. And it may be very systematic, very process-oriented, very driven like the airline industry. There's a reason that the giant airplanes don't crash every day. It's because they go through a similar checklist. Every pilot across the United States and the world almost does the same thing over and over again. And in medicine, we sometimes push that aside and say we're individualists and we want to do our own thing. So I believe creating a system where we have more processes, more algorithms, more points of care, more teams of care that can pick up on the things we do wrong, and then extenuate the things we do right. At the same time, limiting maybe some of the medications that we use that aren't proven to be cost-effective nor evidence-based, and make it more similar across the board. Then I think Alan's right. It won't be in our lifetime, I don't think, unless we spend more than 18% of our GDP on healthcare, which we may do, and it may crash, as they predicted 50 years ago. But I think we'll have multiple payers and have to create that environment. But I lay it on the physicians, because the physicians are the ones that are most resistant to that change, at least that I've seen.
I would argue that it may be a policy issue in this case, because I think there are international models for us of multi-payer systems that then have one pathway in terms of the coverage and the formularies and that type of thing. So I believe Germany and Japan have systems like that where they do regulate the insurance companies so that all the information goes through the same pathway, that the forms are the same. So you reduce all the overhead, this continuously expansive overhead of people's time spent just billing and understanding and going back and making sure the bills are paid and those types of things. So if you have a single system along those lines, I think that's something that the policymakers could potentially handle if they could look at these international models.
So what role does transparency play in that? For those paying or
Just as a consumer of healthcare and as somebody who works with healthcare companies, both for-profit and not-for-profit, I think transparency is somewhat useless unless there's a connection between who's receiving the care and who's in charge of asking for care as a patient and who's paying for that care. I think, like in the Safeway example, you don't really get the benefits of transparency and cost comparison and quality comparison unless there's some real nexus to the patient. I mean, I can go in tomorrow and have many scopes, whether it could be fine and not really hindering me, but I've got a $50 copay. There's not really much nexus. Think of the stent. It's a quick fix. Patients don't really feel it in the pocketbook. I think if there was more of a downside, then people would be more incented not to engage transparency is great, but I'm not sure it'll make much of a difference unless you try to change the payment mechanism.
Okay, so let me circle back around, because we're running close on time. So, in my experience of trying to figure out how to do this stuff, I'll say scale is important, right? If you're the best, it doesn't help unless you can get scale on something. It doesn't help any industry unless they can get it across the way. We've spent a couple decades having the insurance companies try to figure out how to manage healthcare by creating layers of stuff that, disease management, utilization management, PBMs, all the stuff that you guys referenced. We can't make that go away unless we can come to some sort of scalable single system around this. It could be everyone works in one place, or it could be we actually go this road of disruptive collaboration where we actually sit around the table and figure out between two systems, we're going to come up with the same metrics, for instance, or we're all going to agree on something that then we can show scalability and say to the insurers, this is what we're going to do. Whether that has legs or not is dependent upon us, I think, to see if we can do it.
I think Virginia Mason and Seattle, Washington has done a
Exactly.
good job with what you just described. I think clearly, though, when you look at their entire system, they're salary docs, much like the doctors at the Cleveland Clinic. So I think the money part is already sort of removed in some regards because of that. And then they have done a lot of work with the evidence-based medicine and care maps, and they call them value streams. And if a person does not engage themselves with that, then the person is not a part of their team. And I've had multiple conversations with Dr. Mecklenburg, who is their medical director, who oversees that program for the most part. And he basically said, as we continued and as we looked at these different things, they've got about 13 different initiatives now that they're dealing with. If there were providers that just could not see their way to doing it, then those providers were allowed to leave their system. I think we have to get to a point where we're being able to do those kinds of things together. But it's difficult because we're individualistic and we want to, we're capitalists.
But,
Just-
we've